Assalamu alaikum. Good afternoon. You know, it's an extraordinary privilege to be here because this is the first international conference that is happening here in Saudi Arabia. And it is such an important moment to relish. I've had a number of firsts with wound care and hyperbaric medicine in South Africa, and so it's really an honor to be here. And I thank you to our honored guests, moderators, and our colleagues. In return, I would like to share with you today something that has been, if you like, a dream, 17 years in the making, that literally has come together over the past 3 months. And what I hope that this is going to be a new paradigm that is going to shape the way we move towards integrating hyperbaric oxygen therapy in the domain of neurology, neurosurgery, and psychiatry. So as was mentioned, I'm at King Hamad American Mission Hospital. We're in the northern part of Bahrain, in the town of Ali. And we're a small group of 3, all South Africans, so we have a little South African embassy in our department. Sister Husky, you heard speak about transcutaneous oximetry. And in the middle, most important person is my wife, Lucy Cronje, who has kept me on the straight and narrow over the past 3 decades and been such a solid support to me. And in our department, we have 7 different streams. So we do the hyperbaric oxygen therapy as, I would say, the big ticket item, advanced wound care, which is a critical aspect of this, and transcutaneous oximetry with that. I do a variety of consults ranging from aviation and diving medicine to tinnitus retraining therapy, vestibular and balance rehabilitation therapy, and neurofeedback as a board-certified neurofeedback practitioner, and then aviation and diving medicals, having been accepted as an aviation medical examiner by the GCAA and Bahrain Civil Aviation Authority. So I can't take you there physically, but I'd like to just show you our department. So it's fairly small and compact because our mandate is to innovate. So we're in a hospital with 125 beds that's really earmarked in dealing with the challenges in Bahrain and the GCC that can be dealt with in a compact, focused hospital. So you've gone through our department, changing rooms, transcutaneous oximetry area, moving into the main area where our 2 chambers are, which, by the way, we've christened Baloo and the Bagheera. It seemed to work with Bahrain. And there you can see Lucy with a traditional smile. And I'll take you through to our aviation clinic and neurofeedback practice, which is just next door. And here we see pilots, divers, and do neurofeedback, which I'll tell you more about. Now, we've spoken a lot about hyperbaric oxygen therapy, and I don't need to belabor the point. What I do want to mention is how hyperbaric oxygen therapy has had a tortuous journey in trying to find its place in neurology, neurosurgery, and psychiatry. We started in 1908 treating decompression sickness and arterial gas embolism shortly thereafter. Carbon monoxide followed next. Then acute traumatic brain injury, acute stroke, chronic stroke, multiple sclerosis, which was a bit of a disaster because the meta-analyses showed that we didn't make a difference there. We spoke about cerebral palsy and autism as we went through today, and fibromyalgia and long COVID. Now, what has always vexed me is that we are absolutely convinced that hyperbaric oxygen therapy is the definitive treatment of this baric illness, and yet we are completely insecure and often, as I say, confused and vexed about its application in neurology and neurosurgery, even though so many of the mechanisms overlap. And having written these 2 chapters in the second textbook and consensus on hyperbaric oxygen therapy, I had to conclude, looking at stroke at the time, that unless we can combine hyperbaric oxygen therapy with rehabilitation and physiotherapy, which has been shown to be beneficial, and we can show outcomes, we can only say it's a promising area of study. Now, people are shy, Ibrati, and a number of the speakers here have already shown how we are actually branching out into this area. But what I'd like to do is to show how we can do this even better. So where we are today is we know that HBO works. We know it has something to offer in neurological conditions. We have a number of potential protocols we can choose, and we now need to select patients and match them to the protocols for an adequate result. You've seen this slide before, how hyperbaric oxygen therapy mobilizes stem cells, keeps chromosomes able to multiply, protects mitochondria, and in fact makes them divide, modulates the immune system, generates the formation of new blood vessels. All of these incredibly important in neurology. Thanks to these three scientists who received the 2019 Nobel Prize for Physiology and Medicine, we now have a better understanding of hypoxic inducible factor. And one of our previous speakers spoke very eloquently on how this molecule is redefining our understanding. Now that we are aware of the hyperoxic hypoxic paradox, because we now have started to look at what we do through a completely different lens. In previous years, we used to provide air brakes because we wanted to avoid oxygen toxicity. We are now providing air brakes because what that does, it allows us to move from hyperoxia to twice the oxygen that you're breathing here, and that this oscillation from up and down is essentially what resets the body to the new normal at the higher level, and therefore mobilizes this whole myriad of responses that include healing. Now, I would say one of the landmark articles that has really brought us into rethinking what we're doing is this double-blind randomized sham-controlled study that was done on long COVID. I'll talk more about long COVID in a moment, but what this study showed us is that it is not only possible to improve neurological function, it is in fact something that we really ought to be doing if we're practicing ethical medicine. Because you see, if we look at the Oxford clinical evidence-based medicine cascade, if you like, the indications we're talking about here are not at the lower levels of expert consensus. They're on the upper levels, where there already are randomized controlled trials. Not necessarily perfect ones, but we are not as tenuous as we have been in this domain for many years. Now, in long COVID, we need to realize that between 10 and 30% of people who have either had symptomatic or asymptomatic COVID develop long COVID syndrome. In other words, 3 months after the infection, they now have a series or clusters of symptoms ranging from mental fogging, flu-like symptoms when they exercise, all the way through to disturbances in their gastrointestinal tract and in a variety, pick an organ, and there's a symptom that has been attributed to it, and these have been verified. And in this area, we now have 2 randomized placebo-controlled trials, sham-controlled trials, where we have shown that cognitive and myocardial function can be restored. And in the area of cognitive function, it can be restored to pre-morbid levels. In other words, we can take people back in time to the point prior to their COVID episode. We also learned about concussion and traumatic brain injury. And here we saw, again, there are excellent studies. Post-traumatic stress disorder, and I want to pause here for a moment, because when we think about the brain, I had to wrestle with why on earth would hyperbaric oxygen have anything to do with post-traumatic stress disorder. And then I realized this: our brains weigh 2% of our body weight. They use 20% of the oxygen that we breathe. And even then, with an extraction of 13 milliliters per 100 mils of blood as oxygen traverses the brain still needs to have a neurovascular coupling to direct blood flow into one direction or another in order to adequately oxygenate a particular part of the brain. So take someone who's in post-traumatic stress. One part of their brain, typically the right insula, is overactive, which means their frontal cortex and their language centers are simply not available. And they suffer, as many people do, from alexithymia, the inability to give words to the distress they feel. What happens when you put them in a hyperbaric chamber? Suddenly the brain has the luxury of being able to do whatever it needs to. It has adequate circulation. And areas that were in isolation can now be connected. The same is true for fibromyalgia. So this is the hyperbaric side. Let me now talk about neurofeedback. What is neurofeedback? Simply said, neurofeedback is a way to mirror to the eye what the brain is doing in order to train it to do something different. Let me make it even simpler, starting with a client in the middle. A client comes to you with symptoms. They come to you with an EEG, which has been processed as a quantitative EEG, and you now have a balance sheet of what is connected or disconnected within the brain. For instance, if you had a traumatic insult, the gray matter recovers, but it often remains hypermetabolic and it is not reintegrated. In other words, the rest of the brain doesn't realize that that stunned area has recovered. And if you do EEGs, you find that part of the brain idling with an alpha rhythm, desperately wanting to join the rest of the brain, but being unable to do so. With these symptom clusters, you can now use an amplifier, which then goes into typically a laptop, and that generates a video or video game, which then progresses as the person's brain assumes whatever is necessary for recovery. In other words, for the first time, we can actively do rehabilitation. We can actually direct neuronal growth. We can actually enhance neuroplasticity in a directed way rather than simply using oxygenation and hoping for the best, or perhaps using mental maths and puzzles and so on that are good, but are not necessarily specific for what we need. So in clinical neurofeedback, there has also been a progression. We started off essentially in '62 when for the first time it was understood that we can change our brainwaves. And it has progressed all the way through with different protocols to the point where now we actually have a matching of the diseases of modernity that hyperbaric oxygen is addressing and those that neurofeedback has been able to address. So what is the next logical step? Putting them together. And so we can improve circulation, oxygenation, function, reduce inflammation, and accelerate recovery. In doing so, people are restored in terms of their dignity and function, their plasticity of the brain is enhanced, inflammation reduced, emotional regulation restored. Is there evidence of this? Yes, there is. There are studies that have been done in isolation, looking at blood flow in the brain, looking at traumatic injuries, and here some of my co-authors have actually done work. But in this case, the hyperbaric oxygen and the neurofeedback were done in succession. They were not done simultaneously. This being the last study, and this is the important thing that convinced me we need to do this together. Because 195 neurofeedback sessions of 1 hour each, and perhaps 2 hours of hyperbaric oxygen therapy times 300 is not a viable solution. So what happened literally on the 9th of August this year, and in the middle you can see Mohammed Elkholy, who is the representative of Mind Media, who produces this particular neurofeedback device and software package that has been uniquely compatible with hyperbaric oxygen therapy. We have been able to bring the two together. And so you can see the nexus, which is essentially the amplifier that takes the brain waves and through Bluetooth communicates with a laptop which then shows it on the screen. And what you are going to be seeing right now is our very first patient for which we were combining hyperbaric oxygen therapy and neurofeedback simultaneously. This is history in the making. So there's the device. We've used the 19-pin penetrator on the C-crest chamber, and the most difficult aspect of this is because with brain waves, we're working in microvolts, a millionth of a volt, not millivolts as with an ECG. The patient is prepped based on the symptoms. The areas of the brain that need to be trained are identified. The patient enters the chamber, and a series of frequency ranges are set, and thresholds are set, which are either rewarded or inhibited in order to achieve brain stability. We don't realize it, but this technology, just neurofeedback on its own, can reduce grand mal seizures by 65%. We don't realize what technologies are out there, and we're talking about research that is at least 40 years old. So what you see here is the patient looking at a movie and essentially lying in the hyperbaric chamber, and as their brain assumes the range of frequencies that are optimal for better sleep, better concentration, absence of mental fogging, reintegration of a traumatized area of the brain, overcoming a stroke, overcoming an aphasia, they essentially look simply at the screen, and the brain figures out how to get the image there because they want to watch the movie. And it seems almost too good to be true until you look at how powerful the literature is. And the key to the success really has been this 19-pin penetrator, because we were able to do this artifact-free. And we used a number of devices, and the Nexus device was the only one with adequate shielding to do that. So what I'd like to leave you with today, and remember what I'm doing here is showing you feasibility, technical ability, and an invitation to join me in doing research which I believe is essential to be done. In long COVID, traumatic brain injury and stroke, PTSD and fibromyalgia, I believe we are equipped and we have an opportunity to make a difference that in the history of hyperbaric medicine and neurofeedback has not yet been realized, but can be done in synergy. I leave you with the references. I'll make this presentation available to anyone who's interested, and please consider this an open invitation to any of you to join me in this future quest. Thank you very much.